I want to make sure that you are all awake and ready to go. Now, can anybody tell me the color that typically signifies colon cancer? Come on, put it in the chat. Get those fingers working. Wake up those brain cells. Let's go, let's go, let's go, let's go. What? Nobody has put in yet? Oh, we have a response from Bertha Sands, and she is, oh, okay. So we have someone say white, blue. Okay, so we have 2 blues, 1 white. Oh, ruby. Oh, we're getting exotic there. Dr. Cooper, share with them the correct answer. Oh, we can't hear you.
It's ruby.
Ruby. Oh, there you go. Who was that with ruby? I think that was...
No, it's not ruby, but I like that color. So that person gets a point. It's actually blue. Blue has been representing Colon Cancer Awareness Month for many years, with ruby a close second.
Okay, so somebody was looking at the close second. Thank you all for your participation. So who is this guy who is on the screen? Dr. Marcus Cooper is a gastroenterologist and an internist who received his basic medical training at the University of the West Indies in Trinidad. He continued his subspecialty training at the University of Miami-Jackson Health System, where he subspecialized in internal medicine and gastroenterology. Dr. Cooper is an accomplished author, having written several peer journals, and he is also a member of many boards and have been a member of many boards and associations. So without further ado, I present to you Dr. Marcus Cooper, who will be presenting to us today on colorectal screening, best practices and updates. Dr. Cooper.
Good morning, everybody. I hope everybody's awake after that very enthusiastic greeting. Also want to congratulate the person that said ruby. Who came in as a close second for Colon Cancer Awareness Month. Okay, so I am going to share my screen. Can somebody let me know if you can see my screen?
We can see it. You're good to go.
All righty. So I'm going to spend a few minutes today talking about colon cancer screening. As you all know, or as you should all know, this is Colon Cancer Awareness Month. You will have been seeing quite a bit of ads and promotions informing and educating people about colon cancer and Colon Cancer Awareness Month during the month of March. When I first came home in 2009, colon cancer screening was not a priority. And most of the education and information surrounding cancer screening, which is our #1 cancer in the Bahamas. Colon cancer is a close third, but we've done a lot in the past 15 years to bring more awareness about colon cancer screening. And I am honored to be presenting this topic to you because it's one of the utmost importance. All right. So when we're talking about colorectal cancer, we're talking about the colon and the rectum, not to be confused with cancers of the small or cancers of even the anus. Colorectal cancer focuses only on cancers identified in the colon and in the rectum. This is stats provided by the Princess Margaret Hospital Cancer Registry, which is now sort of morphed into the Bahamas National Cancer Registry, showing our statistics on cancer for the country. Unfortunately, all of this is from Princess Margaret Hospital. So there are many patients who receive their care in private institutions or outpatient surgical centers who may not be included in this data. But you can see here, and this information is up to 2018, and I do think we have more current information, but you'll see here that colon cancer is third behind breast cancer and prostate cancer. Sorry. Let me just go back here. All right. Third behind breast cancer and prostate cancer, with about 19 cases per 100,000. So that puts us close to about 80 cases of colon and rectal cancer that we see in the Princess Margaret Hospital system. And the box down on the right-hand side, you'll see that this is taken from 2016 and 17 on average. We had more than 20 additional cases that were found in the outpatient endoscopy center and in doctors' hospital healthcare centers that should have been added to this number. Now in 2024, we're probably seeing somewhere around 120 to 140 cases of colon cancer every year. This is what our statistics look like locally for the age and sex of persons who are diagnosed with colon cancer. So what you can see here in 2018 and 2019 is that the majority of people start to have a diagnosis or are identified with having a diagnosis of colon cancer in their 5th decade. And this picks up in the 60s, tapers off in the 70s. Men and women are equally affected. There's this notion out in the public domain that colon cancer screening is only for men, that it's mostly men that are affected. Women are, for some strange reason, spared. This is absolutely not the case. And our statistics show, and if you were to get p-values on the differences between males and females, it would probably not be statistically significant. Males and females in all age ranges are equally affected by colon cancer. This is some information that Dr. Chandra had pulled in 2016 when we were doing colon cancer statistics, showing where most of our colon cancers are identified when we find them and what location of the colon. So you can see here the majority of them are located in the left colon, the descending colon, with a close second being the ascending colon. You can remember from your anatomy and physiology that colon cancers that present on the left side and the descending colon usually present with obstructive symptoms. And so this is usually what patients will complain about, a change in their bowel habits, which will alert the practitioner, the physician, that something may be going on in that colon. This is also when you're more likely to see blood in the stool, because it has not been broken down by acid, which sometimes happen in the right colon and gives dark stool, but you may have a person complaining of rectal bleeding, bright red blood in the stool. Cancers that are identified in the ascending colon or the right colon tend to be more insidious in onset. You will also remember that stool on the right side of the colon is usually liquid and not solid. And so it takes a longer time for patients to develop any symptoms when they have a colon cancer that's growing in the ascending colon. And these people will usually present with anemia, iron deficiency anemia, and weight loss. Very little obstructive symptoms. So what are some of the risk factors for colon cancer? And these have been proposed globally as risk factors based on population data in countries that have high rates of colon cancer versus those that have very low rates. And a low fiber diet seems to be consistent in most of these studies. And this is the typical Bahamian diet. And I'll show you some information about that in just a bit. But a very low fiber diet, diets that are high in saturated fats, in meats, carbohydrates, processed foods, all of these things tend to or seem to be associated with a higher risk of colon cancer. And this is significant in the Bahamas because our diets are typically extremely low in fiber, if they have any fiber at all. Obesity is another risk factor. And I think the Bahamas is probably the poster child in the region for obesity. We're seeing it in our young people who are becoming adults. Obesity could almost be considered an epidemic. So you can see that the combination low fiber diet and obesity, which is very prevalent in our country, could be responsible for the increasing rates of colon cancer that we're seeing. Patients with inflammatory bowel disease also over time, particularly ulcerative colitis, will develop a risk of colon cancer. Smoking has been identified as a risk factor, as well as family history. And family history is very important, which is why it's important to know your family history. Unfortunately, in the Bahamas, the family tree is often very confusing, and people don't know their family history. And also, there's some cultural nuances in the Bahamas where people typically don't like to tell people about their illnesses, their diseases. They seek attention. They don't want their families around. And so people often don't know until the very end or even after death at the autopsy findings what their family members died from. So having this information is very important so that people can be proactive about their health. What are some of the early symptoms of colon cancer? So this is a slide that I use often when I'm talking to the general population, to lay people about the symptoms of early colon cancer. And there's nothing that comes after this, right? There's nothing that's going to populate the slide. And the reason I do that is to emphasize the point that in its very early stages, colon cancer is often asymptomatic. People will come to the office and say, you know, doc, I don't really feel that I need this because I don't have any problems. I'm having a regular bowel movement. I never see any blood. I feel healthy. I eat pretty good. So I don't see the purpose of having this test done. And nothing could be further from the truth. So we want people to have some form of colon cancer screening when they're not having symptoms so that we can identify a problem early. Once you do have symptoms, that typically means that your disease, if you do have it, is at an advanced stage. And some of the symptoms that people will complain about or present with will be blood in the stool, which is the most common and the most frightening symptom that people have that will prompt them to seek some medical attention. Blood in the stool is never normal. And this is something that I like to reiterate every time I speak to physicians and healthcare practitioners, not to trivialize the presence of blood in the stool, not to assume that blood in the stool is from hemorrhoids, is from anal fissures, whatever the case may be. Let a medical professional, and if you are that person, that medical professional, always have that symptom investigated. Now, the findings may be that this is hemorrhoids, and that's fine. It may be an anal fissure if it presents with pain, and that's fine. But at least you know. Sometimes patients will have hemorrhoids, and they get comfortable knowing that, okay, I have hemorrhoids, and they bleed occasionally, and miss something more sinister. Just had a lady who presented this week who told me that she had hemorrhoids since she was a teenager. And they would come out and she would push them back in, and they would come out and she would push them back in. And then she's now in her 50s, she's 52, and she was unable to push the hemorrhoid back in, to manually reduce it, as we say in medical terms. She went to a doctor, and the doctors put her on Daflon for a few weeks and hoping that this thing would regress, but it actually was a mass. A very large fungating mass that her primary care physician did not really take the time to examine her well and see that this thing was a mass that was adhering to the anal rectal virgin. She was losing weight, and this was indeed a cancer. Anemia, unexplained anemia. Anemia is not a diagnosis. It's never a diagnosis. You should always know why your patient is anemic. If they're a woman of childbearing years and they're having heavy periods, that's an explanation. If they have some sickle cell disease or thalassemia or some other blood dyscrasia, that's a diagnosis. But a patient presenting to you with anemia without a diagnosis deserves some additional workup. It is not appropriate to put a patient, particularly an older patient, on iron tablets and send them on their way, particularly somebody who's over the age of 45, right? Who may not be having any other symptoms. Even if they tell you, I've always been anemic, you should investigate, you should do some additional testing to find out the cause. Unexplained abdominal pain and unintentional weight loss is also some things that people present with. So why do colon cancer screening? What is the reason why we recommend and we advocate for colon cancer screening?
Learn what they is.
Somebody has their mic on. Okay, I'm just going to go back. So this is the theory, this is the concept of why colon cancer screening is so important. And this is called the adenoma to carcinoma sequence. And basically, this is widely accepted as being the pathway and the pathophysiology of colon cancer. It starts off as a healthy colon, and you have some aberration of your tumor suppressor genes, APC genes in most cases. Also, some inflammatory reactions can incite abnormalities of this tumor suppressor gene. And you have then the growth of a very small and benign polyp. And this tends to happen, as you can see, over the course of 30 years or so. So we rarely see these things happening before the age of 30, unless you have some sort of a polyposis syndrome. But at some point, in many people, you will have the growth of a small benign polyp. And then with activation of proto-oncogenes like KRAS, this benign polyp continues to grow. And it usually takes more than 10 to somewhere between 10 and 20 years for this process to manifest itself as a very small polyp to a still benign polyp. And these are usually called tubular adenomas. And when we do colonoscopies, we are trying to identify these small benign polyps before they progress to late stage or late adenomas that have histological findings of precancer or a malignant tumor, which is a carcinoma. So the adenoma carcinoma sequence has been used as the foundation, the basis of colon cancer screening, and why colon cancer screening reduces mortality associated with colon cancer. And this is kind of what the adenoma to carcinoma sequence looks right? So you have somebody who colonoscopy was completely normal, somebody who is further along in that adenoma to carcinoma sequence who will present with a benign polyp, either an incipient adenoma, which is sometimes hyperplastic, or a tubular adenoma, and then a more advanced adenoma. You may not be able to see clearly, but the surface features of adenoma tells you that this is probably, we call these villus features, that this is an advanced adenoma. And sometimes when you remove this polyp and they send it for histological review, they will mention something like low-grade dysplasia or high-grade dysplasia, which we know are precancerous features, and then cancer. And this is what we don't want to see. These are patients whose polyps cannot probably be removed entirely through endoscopic measures and will likely end up having some sort of a surgery. So there are numerous guidelines about colon cancer screening in lots of different categories that I do not want to bog you down with, because I want to make sure that there are some important points that you remember. And so I'm going to keep it simple. Everybody should have some sort of colon cancer screening starting at the age of 50. Everyone. And those are global recommendations. For people of African descent, most, if not all, particularly US and Canadian and European societies, are now recommending that colon cancer screening begin at age 45 in people of African descent. The reason for that is that we found that people of African descent are presenting with colon cancers at more advanced stages and earlier. So instead of presenting in their 50s, you can see from our local statistics that even in the 40s, we're starting to identify people who have colon cancer, and very often stage 3 colon cancers, and even sometimes stage 4. And so globally, it's been recognized that people of African descent, for some particular reason, are at higher risk of developing more severe and more aggressive colon cancer. Hence the reason for reducing the screening age to 45. And locally in the Bahamas, this is what we're advocating. We do have colon cancer screening guidelines we have drafted at the National Health Insurance Authority, which we hope to be releasing. There are some challenges, but for all intents and purposes, as primary care physicians, as medical practitioners, everyone at 50 and people of African descent, which is the majority of our population, should be getting screened at 45. There are different types of screening programs. There are opportunistic and organized. So an organized screening program just means that there are specific policies with specific age categories that have been defined who deserve or who are eligible for colon cancer screening. These policies speak to the method and interval of colon cancer screening and the type of screening modality that's going to be used. There's a management team, some group of people, of healthcare professionals, who are making sure that the appropriate people are getting the appropriate test at the appropriate time. And then also some quality assurance, so making sure that it's a quality test, that the labs are getting the sample in a reasonable amount of time, that there's no degradation of the sample, and the reagent that's being used to detect blood, if in the case of a fecal occult blood test. All of these things are sort of worked into these organized screening programs that some of the more developed countries have. This is not what you see in the United States, unfortunately. This is what you see in places like in Europe and in Canada, where patients are mailed their fecal occult blood tests. And regardless of whether or not they see their primary care physician, they receive this card in the mail based on their age. They're given instructions and they return the card in the mail. They collect the sample themselves, return the card in the mail, and there is processing of the sample, and then they receive some sort of communication as to whether the sample is positive or negative. This is good, when you're really serious and committed about reducing your colon cancer rates. This is the way to go. Unfortunately, it's expensive and it takes commitment, a serious commitment from the government to make sure that the resources are put behind this sort of a program. It is important because it reduces misuse and abuse of your colon cancer screening resources. So people don't just say, and they don't just pop up and say, I want a colonoscopy, because colonoscopies are expensive. So what we employ here in the Bahamas is the opportunistic screening program, where when a patient comes to see their primary care physician, or any physician for that matter, because of their age or if they have symptoms, they're offered some sort of colon cancer screening. This is still good, right? Something is better than nothing, but it does tend to overutilize your resources and inappropriately use your resources at times when patients who may not be eligible for screening are requesting colon cancer screening, and sometimes more often than necessary. Here are some of the methods, which I'll spend the majority of the remainder of my talk speaking about. The stool test, the barium enema, which is falling out of favor very rapidly among radiologists, CT colonography, which is also called the virtual colonoscopy, and then the regular or optical colonoscopy, which is considered the gold standard. So this is what a lot of you see if you're working in the public clinics. This is, and I think these things are still lingering around in the emergency rooms, and probably Princess Margaret and Doctors Hospital. So this is the first generation Hemocult test, the guaiac test. And this is what we've been using, right? I think initially patients would come into the emergency room or whatever, or into the clinic, and a physician would do a rectal exam and smear some stool on the card and put the dropper on it. And if it turned blue or green or whatever it is, then it's a positive test. So for multiple reasons, that's no longer the acceptable standard. And this card is no longer the acceptable standard. We're still using it, and we're actually in the process of trying to make changes. But right now, this is what is in use in the public system. It should be performed annually. It requires 3 cards, so 3 separate samples. And there are numerous dietary restrictions that are associated with this form of colon cancer screening, which often don't get explained to the patient. The Hemocult, the guaiac-based Hemocult test like this uses a peroxidase reaction to detect blood in the stool. And we know that peroxidase is present in foods, it's present in some medications. Patients should be off of vitamin C, multiple things. So we do know that these are not the best tests to be using. Unfortunately, we're still using it. And it's also very unfriendly to the patient have to collect the sample. So we're moving towards the FIT test. And the FIT test is what has become the standard globally for fecal occult blood testing. It uses as the element stool that's detected. The reason why this test is so important now is because globin is degraded by gastric enzymes, by acid. So any bleeding in the upper digestive tract, any blood from the upper digestive tract is degraded by acid, and so you don't detect this blood in the colon or in the FIT test. So the FIT test is very specific for lower gastrointestinal bleeding, which is why it's so effective as a screening test. There are no dietary restrictions. Excuse me. I'm doing a lecture. 1 second. Okay, sorry about that. So more accurate for low GI bleeding, tests of choice for national screening programs. It's easy to administer, easy to collect samples by the patient, specific for lower GI bleed, only requires 1 test, right? So all of those things make it more important. This is the only acceptable standard at the NHI clinics and facilities. When you send your patients for a fecal occult blood test, all of the labs at our NHI facilities should be using a FIT test, and we've confirmed that during our inspections. And hopefully this will become the standard in the public clinics as well. Because what is happening with the first generation tests is that we're getting lots of false positives, so we're not utilizing our resources properly. Patient will come with 1 or 2 positive fecal occult blood tests, you do the colonoscopy, and there's absolutely nothing there. And that usually is because the patients haven't received the proper instructions as to what they should have eliminated in their diet, or they're taking NSAIDs or vitamin C or whatever the case may be. So we really want to move towards the FIT test as the national colon cancer screening test when people cannot afford a colonoscopy. So why the FIT? I mentioned all of these things already. Not only is the FIT slightly better in sensitivity and positive predictive value, but it's so much easier for the patient. National screening programs are heavily dependent on patient compliance. Is the patient actually going to complete the test and send it back? If patients are not comfortable with the, digging in their poop and grossed out or whatever the other case may be, it's difficult to put the sample on the card. They're just not going to do it, right? So the FIT test has been crafted so that it's easy for the patient to collect the sample and send it back. So this is just a meta-analysis. You can't seem to, okay, there we go. A meta-analysis of multiple studies that have compared the FIT test with the guaiac-based first-generation fecal occult blood test. And if you look at that last column on the right, you can see that the positive predictive values are not very different, right? So the sensitivities are a bit better with the FIT test. Positive predictive value, meaning that a patient with a positive test will actually have the disease. Not a whole lot of difference in most of the studies. But they do have good accuracy, and the compliance rates are a lot higher. And because of those compliance rates being so high, these have become the recommended tests for national colon cancer screening guide programs. The other fecal occult blood test is the Cologuard. This is a combination of tests into one stool test that not only detects cancer, genetic components of colon cancer, but it also has components that will identify advanced adenomas. This is actually a decent test, but it's very, very expensive. And it initially was considered to be more of a colon cancer detection test as opposed to a colon cancer prevention test. And now they have multi-targeted stool that, like I said before, will look for colon cancer as well as advanced adenomas. This is not really ready for prime time yet because it's just so expensive. But it is a good test. It is a decent test. And in most cases, this can be the patient themselves. They mail it back into a facility, particularly in the US, and they will get a call just as you would with a programmatic screening program. I won't talk about this slide. Okay, barium enemas. We've been using this forever, right? Patients go into the radiology suite. They have been prepped the night before. You have a probe that's inserted into the rectum. They put some dye in there, and they roll the patient around to see if there are any luminal defects. This is still used, but it takes the hell to get the remnants because it's time consuming and a bit difficult for the patient. So still many of the cancer societies and gastrointestinal societies as an alternative for colon cancer screening or an option for colon cancer screening. Some of the guidelines have totally eliminated the barium enema. But I still think it's a very useful test if you can get a radiologist to perform it. CT colonography or the virtual colonoscopy. You see a lot of advertisements advocating for the use of virtual colonoscopies for colon cancer screening. No sedation is required. There is some preparation of the colon that's necessary to clean out the majority of the stool. There is something in the prep called Tagadol, which sort of coats the stool, and that can be digitally subtracted from your virtual image when the radiologist is reading this. So they're able to give you a relatively good view of what's happening in the walls and the lining of the colon to detect these luminal defects, which usually equate to polyps. And you can see from the pictures, this is kind of what it looks like. Unfortunately, the drawbacks of virtual colonoscopy is that you're not able to remove a polyp if you see it. And I think this is the one big detractor that concerns people when you explain the test to them. So if you do have a positive finding, then you will be referred for an optical colonoscopy, which basically means that you're going to be having a procedure twice. Recommendations by all of the radiological societies and the cancer societies state that this test should be performed every 5 years. And the reason for that is because it doesn't detect polyps that are less than 5 millimeters very well. And so in 5 years, you may have a small polyp that was not detected on your initial virtual colonoscopy that has now grown to greater than 5 millimeters. So you need to have these tests more frequently than an actual colonoscopy. One of the biggest things that you will hear, or one of the primary concerns or complaints that you will hear from patients that do have virtual colonoscopies is that it is not comfortable. Because you don't get sedation, you feel everything. And in the US, I think they're using carbon dioxide, which is easily absorbed from the colon. So the procedure is a little more comfortable. But here, I think the majority of facilities are just using air. And they have a technologist who's insufflating the colon with air. It's very uncomfortable. The patients are often cramping, and they will tell you. I don't want to throw shade on the imaging facilities, but patients will tell you that this is not a comfortable test. And so I think it does not get a lot of repeat visitors because of this. This is just one of this is probably the landmark study that was published in the New England Journal of Medicine, kind of comparing optical colonoscopy with virtual colonoscopies. And it does pretty good, right? You can see number of advanced adenomas. They're similarly detected with a virtual colonoscopy as they are with a regular or optical colonoscopy, particularly between 6 and 10. And this is important. But again, you'll see that all the patients who have polyps detected using a virtual colonoscopy will have for a regular colonoscopy. I guess for those patients who did not have anything detected, they're happy they don't have to do anything for another 5 years. But it's important to tell the patient about the potential for being referred for a regular colonoscopy if there are positive findings. Another benefit of the virtual colonoscopy is the extra colonic findings that you will get, right? So sometimes we pick up incidental lesions that may require further investigation or even treatment. And this does happen, in this particular study, approximately 7% of the time, 7-8% of the time, people will have some finding, whether it's something that needs further investigation or an intervention, but you are able to scan the liver, the pancreas, the gallbladder, the kidneys with the virtual colonoscopy, something that is not possible with a regular colonoscopy. Everybody knows about the colonoscopy. It requires sedation, the preparation. The preparation is always worse than the actual procedure. It's gotten better, and it's getting better, but it's still the more problematic portion of the whole process. The benefits, of course, you're able to see polyps and remove them at the same time. Screening intervals with the colonoscopy, if there are no advanced polyps, answer to 10 years. There is no reason to do a colonoscopy more frequently than that for screening. And even in most cases, if somebody has a colonoscopy in 2020 and in 2024, they present with some symptoms such as rectal bleeding or some abdominal pain. In many instances, it is not necessary to repeat their colonoscopy. If they have some bleeding and it's a lot, and you've identified diverticulosis, it's probably a diverticular bleed, which stops by itself. If they develop a small bleed, it's probably hemorrhoids, and you can treat that with symptomatic and local therapy. But usually in most cases, particularly if it's a quality colonoscopy, the patient had a good prep, they got to the cecum, there was cecal intubation, meaning the entire colon was examined. It is not usually necessary to repeat a colonoscopy so quickly. And this is why it's the gold standard. So just a few words about the preparation. Back in the day, and I do like to say back in the day, citroma was what was being used. Citroma is just pure barbarism. in my opinion. And they would get like 2 or 3 bottles of this to consume the day before. It is violent if you've ever had citroma. If you've ever had a tablespoon of citroma, it's violent. So imagine drinking 3 bottles. So we now have things like Miralax, which is more palatable. You can dump a 238-gram bottle in some Gatorade. It does a pretty good job. We have Colite, which is a gallon, 4 liters. But still, it's easier to tolerate, I think, than the citroma. And now we have some lower volume preps that should soon be available. That's not a full gallon. And so the whole preparation process is becoming a little easier and more tolerable. So here are the screening intervals that you should remember, because these are all acceptable options of colon cancer screening, right? I sometimes get referrals from the clinics, somebody who's had a colonoscopy in 2020 that was normal, and now they're being sent for a colonoscopy for screening in 2024. Not necessary, right? So you can do a fecal occult blood test, particularly or preferably a FIT test every year, and feel comfortable that you're not missing anything significant, because the FIT test is very sensitive to detect these adenomas. Not necessary because, they had a FIT test a few times and you figure, let's just do the colonoscopy. Is that really necessary? Of course, because it is the gold standard, it is expensive. We do it in the private sector. Patients have the ability and we have the resources to accommodate them. But for average risk patients who are unable to afford the gold standard, a stool test is absolutely adequate as a method of colon cancer screening. The CT colonography does have a role, right? Particularly for patients who, for cardiovascular or respiratory issues, are not able to undergo sedation, and your suspicion is low. So if there's bleeding coming out, if there's blood coming out of the rectum, a virtual colonoscopy should not be your first choice, because obviously there's something is there and you want to be able to intervene. So, but for those people who the suspicion is low, um, is flexible colonoscopy every 5 years. We don't do too much of that anymore. And in colonoscopy, every 10 years is the gold standard. Special populations, the elderly. So this comes up often in the clinics. You have somebody who 70 plus, they've never had a colonoscopy, they're relatively healthy. You send them over for colon cancer screening. Not really necessary or recommended. If somebody has gotten to 75 and they have not developed signs or symptoms that would suggest that they have colon cancer, they're probably not going to get it. And there have been multiple studies to confirm that colon cancer screening over the age of 75 should be very selective. And certainly these patients would benefit from stool testing as the primary source of colon cancer screening, as opposed to a colonoscopy. Now, if this is a very fit 75-year-old and you expect that they're going to live for another 20, 30 years, fine, you can have that discussion with them. But in general, well, either not to screen at all, you do decide to screen, to use less invasive method of screening. High-risk populations, first-degree relative diagnosed with colon cancer before the age of 60, then you should be starting in that patient at the age of 40 and then every 5 years, right? So if the patient's mother or father or brother was diagnosed with colon cancer before the age of 60, then you want to start screening them at 40 and then every 5 years. They should not be on a 7 to 10 year interval. First degree relative diagnosed after the age of 60, you can still start at 40, but it doesn't require that more frequent interval. Second degree relative at any age, screen is average risk. If you have more than two or more second degree relatives, you can start at 40 and then every 5 years. And if a person has been diagnosed with colon cancer before, they've had a resection, they've been treated, then they should continue to be screened more aggressively, 1, 3, and 5, then every 5 years. So So the first year after resection and treatment, they should have a colonoscopy, and then the next one should be in 3 years, and then every 5 years after that. Persons with ulcerative colitis, 10 years after the diagnosis of UC, we should be doing colonoscopies on them every 1 to 2 years. Lynch syndrome, we do have some families with Lynch syndrome in the Bahamas where they are at risk of multiple cancers. They should be getting a colonoscopy. And these are all colonoscopies, by the way, and not just fit tests. Starting at 20 to 25, then every 1 to 2 years. Polyposis syndromes, starting at age 10 to 15. Usually we start with a sigmoidoscopy, but these people, once you find it, should be getting a colonoscopy every year. So I should have put this in the risk factor section because this is, I guess the picture on the left would be considered a high fiber Bahamian diet because it does have 2 or 3 pieces of lettuce on the side. There's a lime, which I guess you could count as fiber if you're eating it. But usually this is the extent of fiber in the average Bahamian diet, right? On the right, you actually see no greenery. It's a pretty homogeneous plate of chicken and fries and bread. And so, this is what we grew up on, right? This is what our palates have become accustomed to. This is why every time we pass a facility that's selling fried foods, our car tends to swerve in that direction. And our diets are pretty much killing us, right? We have probably one of the highest rates of breast cancer in the world. A lot of it is genetic, but some of it is also lifestyle related, our increasing levels of colon cancer. The Bahamas is becoming a cancer hotspot, and a lot of it has to do with our lifestyles and our diet. Just a side note, I had a conversation with a friend of mine who is a Bahamian but has been living in the States. She was actually born in the US, and she developed triple negative, BRCA positive breast cancer at the age of 40, 4 months after she had a mammogram and an ultrasound. And when she went to do her genetic counseling, the first question they asked her, who has been diagnosed with cancer that may be genetically related, is, do you have Bahamian roots and are you an Ashkenazi Jew? And so you can see that our gene pool, in combination with our diet, has put us on the map for colon cancer risk. And you can't really do much about your genes, but you can definitely do something about your diet. So what can you do to reduce your risk of colon cancer? All the things that we all know about, but we don't do. Exercise, eating healthy. If you smoke, don't smoke. Drink in moderation, and lose weight, right? We all know it, but we don't do it. It takes too much discipline. But these are the things that can probably reduce your risk of colon cancer, other cancers, and then the other killers in the Bahamas, cardiovascular disease and stroke. So what are some of the take-home points that I would like people to leave with? Start screening at 45, right? And stop at 75, unless there's a good reason to do it. And you have that individual conversation with the patient. Is it really necessary to do some colon cancer screening after the age of 75? If this is a fit person, then there may be some justification to it. The stool test is an acceptable method of colon cancer screening, right? So if you have patients in the public clinics, in the NHI clinics, you use the stool test, use it, and do it annually. Even every other year is better than not at all. And patients who are referred, who have a positive test, should then be referred for a colonoscopy. We don't have the resources in the public setting to do colonoscopies on everybody. We spend most of our time doing diagnostic colonoscopies for people that are in the hospital with hemoglobins of 2 and 3 and 4 and presenting with rectal bleeding and coffee ground emesis and all manner of other things. So the public sector can definitely decrease the burden on what's happening in the hospital with these colonoscopies by just doing what's considered to be an appropriate option for colon cancer screening. And then lastly, anemia is not a diagnosis. So if you find a patient who is anemic and you don't patient, do not put that patient on iron tablets and send them on their way. Thank you very much, and I'll take any questions.
Thank you. Thank you so much, Dr. Cooper. That has definitely been a very, very informative talk. There have been a lot of information that I'm sure that we all can use in our clinical practice. You mentioned something and you repeated it over and over again, and it's very, very important. We cannot see a patient with anemia and feel like it is okay to just put them on meds and send them away. Very important to further investigate such patients. So let us move over to questions from the chat. I have a raised hand. Dr. LaVille, you can go ahead.
Good morning. Thank you very much, Dr. Cooper. Very interesting talk. I had a question. The barium enema, I know it's out of vogue right now, but sometimes patients cannot afford the colonoscopy, and then the clinic may not want to accept them without some investigation, the surgical clinic. So would that be a indication for doing perhaps a barium enema in the absence of the colonoscopy?
So so I'm assuming that you're not talking about screening, right? This is a patient with symptoms, correct?
Yes, correct.
So a patient, go ahead.
Or sorry, with a positive fit test or with symptoms, yes.
Go ahead.
Sorry, I'm talking about a patient
with a
who
positive,
is not screening, but for a positive fit test or FOB or symptoms.
so a positive fit test is an indication for a colonoscopy. They don't need anything else. So a barium enema is only an alternative method of colon cancer screening, as is the fit test. So you don't need to do two forms of colon cancer screening. If you have a positive, if any one of those screening tests other than a colonoscopy is positive, the patient gets referred for a colonoscopy. So a positive fit test by itself is justification for a colonoscopy. They don't need any other screening test.
Okay, so because I have a patient that's been waiting for some time and she can't afford privately, and the public system is taking a couple months longer than we would want. So what would you do in that case?
Right. So if the patient's having obstructive symptoms or they're losing weight or they just seem, usually these patients will get prioritized. When I review these referrals, I prioritize symptoms over just routine positive fecal occult blood tests, right? If you write that in the history, those patients should get priority.
Okay, so if it's just
obstructive symptoms, they're losing significant weight. You're
awesome. Thank you so much.
Go ahead.
Awesome. Thank you so much for the answer. Okay, great. Have a good day.
Okay, thank you for that. We have messages in the chat. Dr. Marcia Bassett, fantastic talk. How do you get access to a fit test?
All of the labs have fit tests, all of them. And if your patient is registered with NHI, the fit test is the only thing that is the only fecal occult blood test that is acceptable for NHI patients. So it's readily available. Only the public clinics are still using the guaiac-based fecal occult blood test. And like I said, we're in the process of trying to convert those as well to FIT tests. So FIT tests are readily available at all of the labs, even for your private patients. If you send them for a fecal occult blood test and you specify FIT, that is what should be performed because all of the labs do have it.
Thank you for that, C. Seymour. Excellent, very thorough presentation.
Thank you.
Do we have any more questions or comments for Dr. Cooper? While you sit and think if you have any more, just a few. Oh, okay. Dr. Gibbs, great presentation, especially in regards to highlighting dietary reformation. It's one of the reasons I decided to give up my beloved Angus beef hot dogs. What are your thoughts on probiotics and colon cancer?
So I don't know of any information, any scientific information, at least the guidelines haven't changed to recommend probiotics as a way to reduce your risk of colon cancer. What I had planned to mention in the slide, and I totally forgot, are some of the medications that have been shown to interrupt or delay that adeno to carcinoma sequence. Low-dose aspirin has been recommended. So the same 81 milligrams of aspirin that you recommend to your patients for primary prophylaxis, secondary prophylaxis for cardiovascular disease and stroke, has shown some promise in reducing the risk of cancer, as well as folic acid. So these are things we don't talk about too much, but I definitely recommend to those people who I do see numerous polyps, particularly if they're at a young age. I would tell them, get on a baby aspirin, and there is some evidence that it helps.
Okay, thank you for that. Bertha Sands, excellent and in-depth presentation, Dr. Cooper. I see a hand raised, E. Anderson. Just before you unmute, I would just like to plug in some public service announcements. Please remember to fill out your CME feedback. I encourage you to do that immediately after the presentation so you do not forget, because I'm sure at the end of the year, everyone wants to ensure that they secure their CME credits in a timely fashion. Also, those of you who are using your phone as your name or initials, kindly change those to your BMC recognized names. Okay, Anderson, you can unmute and ask your questions.
Good morning. I don't have a question, I have a comment. Thank you, Dr. Cooper. Excellent presentation. I like the idea when you talked about the family history with colon cancer. And I realized that one of the myths about it was that a lot of times when you see it in the male generation of your family, persons don't think that the females can have it as well. And so a lot of focus was placed on the males having the colon cancer in the family and so the females felt like they didn't need to do the necessary screenings until it seems as if it switched over to the female. And so I like the thought that you talked about the family, and that the focus should not just be on one side, but both sides can actually be on both sides.
Yes, absolutely. That's a common misconception. But I think we're getting the word out, right? It takes I think we're getting the word out that men and women need to be screened.
Okay, thank you for your comment. I see no more raised hands or messages in the chat. So at this particular point in time, we are going, oh, Dr. Monroe. We have a quick pop-in message from Dr. Monroe. Excellent presentation, E. Marcus. Colon cancer and fecal transplant relationship between human genome and biogenome.
Now, I don't know if that's a question or if that's a statement. Um, but there is, and as the great Dr. Loxley Munro has stated, there's a lot of information coming out about the human genome, and the role that the microbiome plays in health and disease. So the microbiome is the plethora of organisms, bacteria and others that live inside the gut that seem to modulate and influence health and disease. And this was the basis of fecal microbiota transplants. Initially, a lot of the data showed that, and as far as I'm aware, still does, that in select populations, and we used it heavily at University of Miami in patients who had C. difficile, recurrent C. difficile, that if you transplanted healthy stool or stool from a healthy donor into someone who had recurrent and resistant C. difficile, that you can modify the course of that disease. And out of that initial research came the other theories about the microbiome and how it can influence other chronic illnesses like diabetes, inflammatory bowel disease, etc. So there's lots of research about the microbiome and how it influences health and disease. Right now, C. diff is the only clear-cut indication for fecal transplant. I don't know if there's a lot of fecal transplants being done anymore, but certainly alteration of the microbiome is very important, and there is some interaction and some relationship between organisms in the gut, which is why probiotics have sort of taken off in favor, become popular and in vogue with gastrointestinal diseases. So we recommend probiotics for patients who have irritable bowel syndrome. There's some evidence that probiotics can help. We know that it works well in antibiotic-associated diarrheas and traveler's diarrhea. Probiotics seem to decrease the duration of the illness. But I think there are also some misconceptions about the benefits of probiotics. We tend to give it for everything, for unexplained abdominal pain, for ulcerative colitis, for diverticulitis. And I don't know if there's good information out there, good science to say that it helps in all these conditions, but certainly I do tell patients that it usually doesn't hurt. And so if we're working people up for symptoms and we can't explain it, and we don't see any real structural abnormalities that will get better from medication, I do try probiotics. And some patients benefit and some patients don't.
Okay, thank you for that. And we're going to wrap up with these last two comments in the chat. Good morning, all. And this is from Dr. Jacobs. Great talk. As always, very informative. Question: have you seen a steep increase in cases of colon cancer since the COVID-19 pandemic? And if so, what are your thoughts on the reason? Obesity, decreased screening?
I can't say that I've seen an uptick in colon cancer diagnosis since the pandemic. So, the pandemic is kind of like the birth of Christ, right? Everything is either pre-pandemic or post-pandemic. So, sudden cardiac deaths we seem to be seeing a lot more of them. And there's this theory that this is somehow related to the vaccine and things like that. And I can't say that I've seen more colon cancers since 2020 than I saw before. The statistics will bear out and show if there has been. But what I can say that we do have more screening going on because people are becoming more comfortable with the idea of having a colonoscopy. And then they have the opportunity to ask about other forms of colon cancer screening. Primary care physicians are now more than ever routinely sending patients for a colonoscopy in the private sector. And I think in at least talking to patients, have you had a colonoscopy or some form of colon cancer screening? So I think we're doing a better job at screening than we were before. I am certain that we're seeing more cancers in general. And this is kind of off topic, but definitely more pancreatic and biliary cancers than I've ever seen. We seem to be getting these almost weekly, certainly more than one or two a month. The reason for this is unsure, but we hope to be collecting some data about this soon. And hopefully we'll have more information.
Okay, thank you. Excellent presentation, very reassuring and informative talk. Thank you. That's from Dr. Roka Davis. Excellent presentation, Dr. Cooper. Thank you. If we refer patients from the public clinic to the public lab, I'm not sure if that's supposed to be private lab, and specifically ask for FIT tests, is there an additional cost to the patient?
Right. So I don't think I know that the PMH lab doesn't have the FIT test. So if you send your patient to PMH lab, they're not going to get a FIT. They're going to get the regular fecal occult blood test. So if you want to make sure that your patient gets a FIT, send them to their NHI provider. If they don't have an NHI provider, they should register for one. Or you can send them to a private lab and request a FIT. I think the FIT test is less than $20. So they can get it with a referral if you specifically ask for. I think the labs also do carry the first generation fecal occult blood test, but if you specifically say FIT test, all of the labs should have it.
Okay, thank you for that. And lastly, we have a message in from Dr. Marcia Bassett, who wants to put in a plug for Colon Cancer Awareness Walk on Saturday. Get your rare in gear. And she would love to have all of you join in on that very exciting walk. It will be at Goodman's Bay at 6:30 a.m. And with that, my dear colleagues, we have come to the end of another very informative CME session, and I am proud to say that you have officially leveled up in your knowledge. We hope that you have an excellent, super productive day. Remember, it's not hum day, it is a great day, and we will see you at our next CME session. Have a great day.
Thank you.